Hi and welcome. I'm Professor Shaibu Oricha Bello, and over the next few slides I want to take you through something I find genuinely fascinating: how we fight viruses with drugs. Now think about that for a second. Bacteria have their own cell walls, their own ribosomes, their own metabolism, so we have plenty of targets. Viruses, they hijack your cells. They use your machinery. So how on earth do we kill the virus without killing you? That's the whole story of antiviral pharmacology, and it's the question I want you to keep in the back of your mind the entire way through. We're focusing on the non-retroviral agents today: herpesviruses, influenza, hepatitis B and C, and SARS-CoV-2. Whether you're a student sitting exams or a clinician prescribing these drugs on Monday morning, stay with me. Let's get into it. Here's our roadmap so you know exactly where we're going. We start with foundations because if you understand the replication cycle, half of this topic memorizes itself. Then we work through 4 families of agents: the anti-herpes drugs, the influenza drugs, hepatitis B and C, and the newer SARS-CoV-2 agents. And we finish with the themes that cut across all of them: resistance and drug interactions. Now, a small piece of advice: don't try to memorize this as 6 separate lists. Try to see it as one repeating pattern. How does the drug get activated? What does it block? What organ pays the price? And how does the virus escape? 4 questions, every drug, every time. If a section is particularly relevant to you, the timestamps are in the description. Let's start at the beginning. This slide is the map for everything else, so let me walk you through it. A virus attaches and enters your cell. It uncoats, it copies its genome, it makes its proteins. Then it assembles and escapes to infect the next cell. Every single one of those steps is a place where we can intervene, and every drug we discuss today lives at one of those arrows. Entry and uncoating, that's amantadine and docosahexaene. Genome replication, that's the enormous nucleoside analog family. Protein processing, that's the protease inhibitors, and if the name ends in privar or you're thinking of namatrelver, that's where it acts. Assembly and release, that's oseltamivir. Here's the punchline at the bottom: most non-retroviral antivirals hit genome replication. So if you master nucleoside and analog pharmacology, you've mastered most of this topic. Now let's talk principles, because these 4 ideas explain almost every side effect you'll ever see with these drugs. First, viruses are obligate intracellular parasites. They use your enzymes, so truly viral specific targets are rare, and that's why the older agents have such a narrow therapeutic index. Second, and this is beautiful, many of these drugs are prodrugs activated by a viral enzyme. So the drug essentially arms itself only inside infected cells. Third, these agents are virostatic, not virucidal. They suppress replication. Your immune system does the actual clearing. And that's why aciclovir doesn't cure herpes. It doesn't touch latent virus in the ganglion. Fourth, timing. Viral replication peaks early. Start late and you're treating a battle that's already been fought. Remember, then we get to influenza and COVID. Here's the whole cast of characters on one slide, and I'd suggest you screenshot this one. 4 groups. The anti-herpes agents dominated by the guanosine analogues, plus foscarnet and cidofovir when resistance shows up. The influenza agents, 3 neuraminidase inhibitors, baloxavir, and the adamantanes that we essentially no longer use. The hepatitis agents, where hepatitis B is about long-term suppression with entecavir and tenofovir, while hepatitis C is about curative direct-acting antiviral combinations. And finally, the SARS-CoV-2 and broad-spectrum agents. Notice something. Look how many of these are analogues of a normal nucleoside or nucleotide. The virus mistakes them for building blocks, and that mistake is fatal to it. That single trick underlies drug after drug on this slide. Let's start with the classic family. Section 1, the anti-herpes virus agents. Now, this is where antiviral pharmacology was born, and it's still the cleanest example of selective toxicity we have in this entire field. We're talking about herpes simplex 1 and 2, varicella zoster, and cytomegalovirus. These are viruses most of us carry for life. They hide in nerve ganglia or in white cells and wait for us to be stressed, immunosuppressed, or simply older. 2 things I want you to take from this section. 1, the elegance of how acyclovir switches itself on. And 2, the pattern that when a drug needs a viral enzyme to activate it, losing that enzyme is the virus's easiest escape route. Keep that in mind, and the resistance patterns will make perfect sense. Let's look at acyclovir. If you remember one mechanism from this whole video, make it this one. Acyclovir arrives as an inactive prodrug. Step 1, if viral thymidine kinase adds the first phosphate, and here's the key. That enzyme only exists in infected cells. That single step buys us roughly 100-fold selectivity. Step 2, your own host kinases finish the job, giving acyclovir triphosphate. Step 3, that triphosphate competes with the natural substrate at the viral DNA polymerase, gets incorporated, and because it has no 3' hydroxyl group, the chain simply stops. Dead end? Beautiful, isn't it? Now look at the consequence at the bottom. If the virus loses thymidine kinase, the drug never gets switched on. That's the commonest resistance mechanism. It shows up mainly in immunocompromised patients, and it knocks out valacyclovir and famciclovir too, because they all depend on that same first step. Same family, different packaging, and this table is really about bioavailability. Plain acyclovir orally is poor, only about 15 to 30% absorbed, which is why the dosing is so frequent and why severe disease like HIV encephalitis goes intravenous. Valacyclovir is simply a cyclovir with a valine attached. Your gut and liver esterases strip it off, and absorption jumps to around 55%. Famciclovir does the same trick for penciclovir. So the mechanism is identical, the pharmacokinetics are what you're actually choosing between. Clinically, that means fewer tablets a day and better adherence. 2 safety points I want you to carry into practice. Keep patients hydrated and don't push an intravenous infusion fast, because acyclovir can crystallize in the renal tubules. And in renal impairment or the elderly, watch for the neurotoxicity, tremor, confusion, sometimes frank agitation. Now we move from herpes simplex to cytomegalovirus, and the drug is ganciclovir. Structurally, it's a cousin of aciclovir, but the activating enzyme is different. It's the CMV-UL9 phosphotransferase. Valganciclovir is the oral prodrug, and it transformed the management of CMV in transplant patients. Where does it matter? Retinitis, colitis, transplant prophylaxis, and congenital CMV. But look at the red panel, because this is the honest part of the conversation. Ganciclovir is myelosuppressive, neutropenia in up to 40% of patients. Add zidovudine or mycophenolate and you're stacking marrow toxicity on marrow toxicity. In animal studies, it's carcinogenic, teratogenic, and impairs spermatogenesis, so we handle it like a cytotoxic. Practically, check a full blood count weekly and counsel about contraception. This drug demands respect. So what do you do when ganciclovir stops working? That's where these two come in, and they're worth knowing because they solve the problem in a completely different way. Foscarnet isn't a nucleoside at all. It's a pyrophosphate analog, and crucially it needs no activation step, no kinase required. So thymidine kinase deficient herpes and UL97 mutant 905 are both still susceptible. Cidofovir is a nucleotide. It already carries a phosphonate group, so it also skips the viral kinase. Now the price. Foscarnet is a nephrotoxin and an electrolyte disaster, low calcium, low magnesium, low potassium, and if calcium drops far enough, seizures. Cidofovir's nephrotoxicity is dose limiting, which is why we never give it without intravenous saline loading and oral probenecid. These are salvage drugs. You reach for them deliberately and you monitor closely. Section 2, Influenza. Now, the pharmacology here is short, but the clinical judgment is everything, and that's really about timing. Influenza replicates explosively and then burns out. By the time your patient has been unwell for 4 or 5 days, the virus has largely finished its work, and what you're seeing is the immune response. So an antiviral started then does very little. We have 3 targets in this section: neuraminidase, the enzyme that lets new variants cut themselves free from the cell surface; the polymerases cap-snatching endonuclease, which is baloxavir's target; and the M2 ion channel, which is a lesson in how quickly resistance can end a drug's career. Let's take them in turn. Neuraminidase inhibitors. Picture this: new virus particles have been made. They're budding off the cell surface, but they're stuck, glued by sialic acid. Neuraminidase is the scissors that cuts them free. These drugs are sialic acid look-alikes that jam the scissors, so the progeny variants clump on the cell and never spread. Oseltamivir is your oral workhorse, 75 milligrams twice daily for 5 days, and remember to reduce the dose in renal impairment. Take it with food. That markedly reduces the nausea. Zanamivir is inhaled, so avoid it in asthma and COPD because it can trigger bronchospasm. Peramivir is a single intravenous dose for someone who can't take anything orally, and that line at the bottom is the honest one. In a healthy adult, this buys you about a day. In high risk and hospitalized patients, it matters much more. 2 very different stories on this slide. On the left, baloxavir, which I think is genuinely clever. Influenza can't make its own mRNA caps, so it steals them from your cells using an endonuclease. Baloxavir blocks that theft. One single oral dose and viral shedding falls faster than with oseltamivir. One practical trap: don't take it with milk, antacids, calcium or iron, because those cations bind the drug and absorption collapses. On the right, the adamantanes. These block the M2 proton channel and prevented uncoating, and for influenza A they worked well until a single amino acid change, S31N, spread through circulating strains. Now resistance is essentially universal, and we don't use them for influenza. Amantadine survives in Parkinson's disease. That's a real world lesson in how fast a good drug can be lost. Section 3, Hepatitis B and C. And I want to frame this properly because these two viruses sit in the same organ, and yet we treat them with completely opposite philosophies. Hepatitis B is a DNA virus that parks a stable template inside the nucleus, so our drugs suppress it, often for life, but they very rarely eliminate it. Hepatitis C is an RNA virus with no such reservoir, and that's exactly why we can cure it in 8 to 12 weeks with tablets. In one generation, Hepatitis C went from a disease treated with a year of interferon injections and dreadful side effects to a short oral course with cure rates above 95%. That is one of the great success stories of modern pharmacology, and I never get tired of saying it. For chronic hepatitis B, your first-line agents are antiviral and tenofovir. Why those two? Potency plus a very high barrier to resistance. Compare that with lamivudine, where roughly 70% of patients develop resistance by 5 years, which is why it's fallen out of favor. With tenofovir, know your formulations. The older TDF is associated with renal tubular injury and reduced bone density, while TAF delivers the same drug with a friendlier renal and bone profile. Practical points: entecavir on an empty stomach. Pig interferon is the one finite duration option. But flu-like symptoms: cytopenias and depression limited, and it's contraindicated in decompensated cirrhosis. And please read that warning line, because it catches people out. Stopping these drugs abruptly can trigger a severe hepatitis flare. This is generally long-term therapy. Hepatitis C, and here's the good news: the naming convention does the work for you. Prevar means an NS3/4A protease inhibitor, blocking the cleavage of the viral polyprotein. Asvir means an NS5 inhibitor, disrupting assembly of the replication complex, and these are extraordinarily potent. Buvir means an NS5B polymerase inhibitor, with sofosbuvir as the pangenotypic backbone. Learn the 3 suffixes and you can classify almost any regimen you meet. We combine them because attacking 3 targets at once crushes resistance. Now the practice points, and the first one is a safety issue I want you to remember. Screen every patient for hepatitis B before starting, because reactivation can be fatal. Watch amiodarone with sofosbuvir. That combination causes bradycardia. And beware inducers: rifampicin, carbamazepine, even T. John's wort, which can quietly sabotage a cure. Section 4, SARS-CoV-2 and the emerging viruses. Now, most of you lived through this in real time, and it was an extraordinary demonstration of antiviral pharmacology being built in public. But the principles didn't change at all. We still went after the polymerase, and we still went after the protease, exactly as we had for hepatitis C. What COVID really taught us, or perhaps retaught us, is two things. First, timing is everything. These agents work in the viral replication phase, not the inflammatory phase. And second, drug interactions can matter as much as the drug itself, as you're about to see with Retroviral. Let's look at the three agents you're most likely to encounter. 3 drugs, 3 different tactics. Retroviral blocks the main protease, so the viral polyprotein never gets cut into working pieces. And Retroviral, it has no antiviral role here at all. It's a potent CYP3A4 inhibitor deliberately added to stop nirmatrelvir being metabolized. That's why interactions are the main hazard. Statins, amiodarone, rivaroxaban, tacrolimus, some antipsychotics. Always run a full medication review before you prescribe it. Remdesivir is intravenous, a nucleotide analog prodrug that causes delayed chain termination of the viral polymerase. Molnupiravir is the odd one out and the most conceptually interesting. It deliberately introduces so many mutations that the virus's genome collapses. Error catastrophe. Because of that mutagenic mechanism, it's contraindicated in pregnancy and in under 18s, and it's a reserve option. And for all three, start early. These two panels are, I'd argue, the most clinically valuable slide in this whole session. On the left, resistance. Notice the pattern we keep seeing. The virus's first move is usually to lose the enzyme that activates our drug, thymidine kinase for acyclovir, UL907 for ganciclovir. Its second move is to alter the target itself. And who develops resistance? Immunosuppressed patients, people on prolonged low-dose exposure, people struggling with adherence. On the right, the interactions worth committing to memory. Ritonavir and CYP3A4. Ganciclovir stacked with other marrow suppressants. Foscarnet or cidofovir alongside aminoglycosides or contrast. That's additive kidney injury. Baloxavir with calcium or iron. Sofosbuvir with amiodarone. If you take a photo of one slide today for your clinical practice, honestly, make it this one. So let's bring it together. 4 ideas. One is selectivity usually comes from activation, not just from the target. Viral kinases concentrate the active drug where it's needed, and when the virus loses them, that's your first road to resistance. 2, timing determines benefit. Influenza and Antivirals are early window drugs. Herpes treatment works best at the prodrome. 3, know the organ at risk for each class. Kidneys for acyclovir, Foscarnet and cidofovir. Bone marrow for ganciclovir. The central nervous system for the adamantines. The liver for interferon and the protease inhibitors. 4, suppression versus cure. Hepatitis B needs indefinite therapy. Hepatitis C is cured in weeks. If this helped, do subscribe and put your questions in the comments. I read them. Thanks for watching, and I'll see you in the next one.